Okay, hi everyone. I'm Tyla. I'm one of the medical officers that works in the Peds outpatient department. I chose this topic partly because I feel like you can never know enough about it. I certainly don't. And it is a very, very common presentation, both EDs as well as outpatient departments. Oh, no, I'm not moving along. You can't see me moving along.
No, not yet. So if you look on
Oh,
your
there.
computer to
Sorry.
the little space bar, yeah.
Okay. So I've just broken it up into introduction, acute rhinosinusitis, which is essentially a common cold if it's viral, acute pharyngotonsillitis, acute otitis media, acute bacterial rhinosinusitis, epiglottitis, and quinsy. I'm literally just going to touch on. And then antibiotic stewardship, which I feel like is one of the main reasons I'm doing this talk. And then hopefully I can answer some questions if there are any. So I'm not going to go into the anatomy like too much of the upper respiratory tract, but just to understand that all the structures that are in the upper respiratory tract can essentially become infected, and then that same infection can lead to complications. So yeah, whether they're infected with a virus, a bacteria, or even a fungus, just to understand that the nasal cavity can become infected, the pharynx, the tonsils, and yeah, so we'll just touch on those different anatomical areas and the pathology that comes with it. So upper respiratory illnesses, specifically due to viral infections, are possibly the most common reason that patients, especially children, present to general practitioners and clinics. So in the Peds outpatient department, about 50% of the patients we see have some kind of upper respiratory tract infection, whether that is the reason for presentation or whether it's a coincidence that they're there for something else. It's a very, very common presentation. Like I've mentioned earlier, all the structures that make up the upper respiratory tract can become infected, and we will go through that as we go through the presentation. And the upper respiratory tract, the purpose of it is allows us to speak and to breathe, and it conditions the air in terms of temperature as well as moisture. We all know on a very cold, dry Joburg winter, that feeling of dry air that enters into your nose and throat is not very comfortable. But generally what the upper respiratory tract tries to do is to moisture that air and to manage the temperature. Actually having a clear nose gives you a sense of well-being. So if you have a blocked or stuffy nose, you don't feel very well, which has always been a very interesting thing for me because it's such an innocent thing, but it makes you feel quite sick. I'm just going to mention this largely because I see children, except in the ED, but depending on the age of the child, the presentation will be different. So if a neonate came in with an upper respiratory tract, so an acute otitis media, they would present very differently to a 6-year-old. For example, a neonate would present with irritability, poor feeding, may have pyrexia, may have lethargy, whereas a 6-year-old could very clearly tell you that they had a sore throat, or a 2-year-old could be tugging at the ear. So just important to understand that depending on the age of the child, there's a very different presentation. And then the same said for an adult. An adult can quite clearly tell you where they're having pain or discomfort. And then, like I said earlier, the take-home message, hopefully, is when to prescribe antibiotics. This is not very clear because there are different schools of thought. And yeah, obviously every clinical case is managed differently. But if we can just take home from today when to prescribe and when not to prescribe based on general guidelines, I think it would be quite helpful. So rhinosinusitis can be broken up into acute viral rhinosinusitis, which is essentially the common cold. I don't think anyone has not had a common cold. It makes up, most of us who are unwell at any given time, it is due to a common cold. You'll see the diagram below mentions post-viral acute rhinosinusitis. I'm not really going to go into that, but essentially that's when symptoms persist past day 5. Generally with a common cold, your symptoms should start to improve around day 5, and then if they don't, you may be dealing with something else. Acute bacterial rhinosinusitis, we will go through, that can have quite significant complications and needs to be diagnosed adequately. And then chronic rhinosinusitis and allergic rhinitis, we see a lot of, especially being based up in Gauteng. So the common cold, runny nose, cough, watery eyes, sneezing, we all know that awful feeling. And I think if there's a take-home message from this, it's basically that clinicians need to know the natural course of a common cold. and therefore any deviation from the normal can therefore be managed effectively, and you would then know whether you're dealing with a secondary infection or whether you're dealing with something that wasn't as innocent as a common cold as you may have initially thought. Something that I have learned over the years, and I think we were all taught this, and still moms come in and they say, oh, but doctor, the nose is yellow, the green snot is coming out, and we immediately think then that possibly is a bacterial infection. But this is actually not true. Clear secretions can and do often become purulent, and this is not a suggestion of a secondary bacterial infection. So if we just plug that into the normal course of a common cold, it may change antibiotic stewardship. Understanding also that 75% of common colds are still symptomatic on day 10. This does complicate things somewhat. And that 2/3 of them have transient middle ear changes. This does not mean they need an antibiotic, but it could very well predispose to an acute otitis media. Then I thought this was interesting, especially in light of the ED. Changes are often evident in sinuses on CT. So we all know when we send off a child for a scan for trauma, and they come back and the CT brain is no intracranial pathology, but sinusitis noted on CT. And that's just that generally a common cold will have changes on CT scan. And again, that does not mean that you necessarily need to be giving an antibiotic. I really enjoyed this. I thought that this was, if we could kind of all lock this into our minds when we're seeing patients, is that nasal stuffiness and throat irritation is almost like mainstay for most patients. A low-grade fever, malaise, and myalgia is very common. And then you can have the sneezing, watery nasal discharge, and very important to understand that 60 to 80% of cases will be coughing, and this does not imply a secondary bronchitis or secondary pneumonia. And if you manage to counsel patients adequately on this, then they won't be coming back unnecessarily. Also to understand, like I mentioned earlier, that many become mucopurulent on day 1 to 3, and this mucopurulent secretion can persist up to 10 days in 31% of cases. And if this goes on to become a postnasal drip, that can go on for up to 4 to 6 weeks. So again, just understanding that this forms part of the normal course of a common cold. I have read quite a bit on this and trying to understand about, can you distinguish clinically a bacteria from a virus? And essentially the thinking is you actually can't. And so there needs to be a shift in the paradigm in that we need to approach it from a severity point of view and treat each individual as an individual, as opposed to just following diagrams. But also just if you have this diagram in your mind, you'll understand what a common cold should present with and what forms within the realm of normal. So treatment, basically your treatment of a common cold is symptomatic relief and supportive management. If you counsel and you take those 2 to 3 minutes, a little bit longer at the end of your consult, and reassure the parent, making them understand that you do know that the child doesn't feel well, and not just dismissing them to say, oh, it's just a cold. If you do that well, they most likely will not present the following day at 2 a.m. to the ED saying, but my child is still coughing. Sometimes it's just to help them to understand that you know that the child doesn't feel well, but it still doesn't warrant further medication or further workup. And sometimes if the parents just feel heard on this front, then you've done your job. You can give them safety net information, counsel them about red flags and when to come back. Well, not can, you should. Because like we said, if you know the normal course of a common cold, you should then counsel what the deviation from normal would be. Analgesia, I know this can be controversial, especially with one of our newly appointed professors in our department, but analgesia is really important. And me being a mom, if you treat a fever and you treat pain, then you've done a really good job. So do it properly, give a correct dose according to the kilograms of the child, and consider an anti-inflammatory. There's nothing wrong with prescribing paracetamol and ibuprofen together, and in fact, giving them together works very well. In terms of congestion, also lots of different schools of thought, but normal saline has been proven to show a modest reduction in symptoms, which is quite important because it's such a simple thing. And our pharmacy now has normal saline back in stock for the first time in months, I actually want to say in a year. Decongestants are actually a little bit controversial, especially in children, but they are proven to be quite helpful in adults. And then the same for antihistamines. They can have short-term benefits in adults, but generally not recommended for children. The same for steaming and mucolytics. ACC 200 is often prescribed, and from a personal point of view, I feel like it works quite well, but the studies are still out there. In terms of the cough, like we said, 60 to 80% of individuals go on to get a cough. There have been studies that have recently shown that honey works as well as over-the-counter cough syrups. So, yeah, it came out the same, and obviously it's a natural product, so definitely would recommend moms to use that, but just to caution that it cannot be used under the age of 1. Then herbal medications, a lot of new studies with regards to Sinupret, which is BN1016, also can be controversial, but the studies have proven that it can be beneficial, and it's actually safe across most age groups and safe in pregnancy and breastfeeding moms. Then hydration. So hydration is an important point, and that leads to the next one of when to admit, in the sense that if an individual, particularly we're talking your young infants, if they're not feeding well, they will become dehydrated. Babies are nose breathers, and therefore if their nose is blocked, they won't be able to breathe properly and they won't be able to feed at the same time. So this could be one of the reasons for admission if a child is really not managing to feed. And sometimes even if it's for normal saline and suction of the nose in order for them to feed properly and just to tide them over the initial day or so when the symptoms are the worst. And then when to consider an antibiotic. So biphasic illness, so essentially the child or the adult is getting better, and then all of a sudden there's like a new fever or new symptoms, that may be an indication that there's a secondary bacterial infection. Progression of symptoms. So essentially not that the symptoms are essentially getting worse. And if we remember that initial diagram, so around day 5, when you would expect the common cold to start to be settling, they may just be getting like ongoing symptoms. Or another reason is no improvement. This is a tough one because 3 out of 4 are still symptomatic on day 10. So it's a tough one, but I think, if you have a good history and a good examination, you may be able to make that decision with regards to antibiotics, but generally not needed with a common cold. So chronic rhinosinusitis and allergic rhinitis is a really important thing up here in Gauteng. We have one of the highest pollen counts, and we don't really have a dip. So ours is, obviously our pollen count is worse in specific seasons, but it doesn't dip as it would necessarily in other climates. So if you treat the allergic rhinitis well, then often you may prevent common colds, because having allergic rhinitis actually predisposes you to common colds. It's quite difficult to ascertain whether it's chronic rhinosinusitis or allergic rhinitis, but a good history would be able to provide this. If you have a look inside the nose, it's often easy to see like enlarged erythematous turbinates, and this may be an indication of allergic rhinitis. It's important, particularly in children, that if there is upper airway obstruction, this can lead to sleep apnea and the consequences thereof. We have had patients who have developed cor pulmonale secondary to upper airway obstruction, so it is really important that we manage this properly and appropriately. The treatment is generally intranasal steroids, which we do have at our pharmacy. We have fluticasone. It's quite nice because it's a local thing. You're just spraying it into the nostrils. And then antihistamines. We have both first and second generations at our pharmacy. Second generations are obviously better and they're safer. The first generation, like your chlorpheniramine, which is your Allergex, can be very sedating. And in children under the age of 2, they can actually have paradoxical reactions to it. So if you have access to Alicet, which is your cetirizine, that is superior, and it has recently been made safe from children aged 6 months and onwards. So definitely available for us to use. Nasal douching, very, very helpful. That goes back to your normal saline. The principle here is the flushing of the allergens. Not easy to do with children, but it is definitely very helpful. And then allergen avoidance. There are lots of different things you can do if a child has significant allergic rhinitis. There are things you can do with how you wash the bedding, what you do with soft toys. But in terms of allergen avoidance in our environment, that's often quite tricky. But yeah, I just thought I had to mention allergic rhinitis because we see so much of it. This was quite helpful for me, just having a look at the symptoms that would suggest allergic rhinitis versus a common cold. There, your duration is obviously quite important, so you need a good history. You may have a patient or a parent telling you that the symptoms are worse specifically when exposed to allergens. And generally this is like a chronic or a recurrent presentation. The watery nose, sneezing, nasal obstruction, itchy nose, so they often have the allergic salute, they have allergic shyness, and often it is in association with allergic conjunctivitis, possibly with asthma as well, and even with eczema. So that would generally lead you towards allergic rhinitis. So always important to manage that. And then the common cold, like we went through, is generally your sore throat, severe nasal congestion, rhinorrhea, sneezing. But yeah, I think we all generally know the common cold symptoms, and then that would be as per what we spoke about earlier. And then some of the things that would suggest that it's not a common cold, which I found quite interesting, was unilateral symptoms. So yeah, I mean, if it is unilateral, you're thinking more along the lines of a sinusitis. And just some of the other things along here, facial pressure, that's thinking more of a sinusitis as well, obviously orbital cellulitis. Here they mention mucopurulent rhinorrhea, which I found was quite interesting because we've actually just gone through the fact that it is very normal. But yeah, I just thought that this was an interesting thing to add in. So acute bacterial rhinosinusitis, only 0.5 to 2% of common colds will actually result in a secondary bacterial infection. And generally it's normally preceded by a viral upper respiratory allergies, trauma, or dental infections. Yeah, important to understand that because acute bacterial rhinosinusitis needs to be managed appropriately. Generally, what would make you think that it's a sinusitis or a bacterial one is these three clinical presentations. And that is that the symptoms, the nasal symptoms, persist past 10 days. So again, going back to that diagram to say that at day 5, the common cold should start to be getting better. And at day 10, most people should start to feel much better. And what they're saying here is that the symptoms got on for more than 10 days, less than 30 days, and without any improvement. So that's not like they've said, oh, I felt a little bit better on this day. It's just not necessarily progression, but just without improvement. And then severe symptoms on onset, temperature more than 39 degrees, a purulent nasal discharge. So this, again, important to see here that they're saying severe symptoms at onset. So a purulent nasal discharge at onset, not that it started like a common cold, and that they may be quite ill looking, or worsening of symptoms, like we went through the biphasic illness or double sickening at around day 6 or 7. This is basically essentially saying the same thing, and just, yeah, really important to pick up these patients because of complications. So our job is always to be safe doctors, and to pick up complications early and to treat them. So most of the complications that come from acute bacterial rhinosinusitis arise from orbital or intracranial extension, and orbital being the most common. I actually found this quite interesting because we always talk about preseptal and postseptal, but you can actually differentiate the two clinically, and this is important because whether you need to do imaging or not. So preseptal cellulitis, you can normally tell the difference because there is not as much ocular, well, there isn't ocular pain. So pain on movement of the eye suggests that it's most likely postseptal cellulitis, and therefore imaging is really important. Intracranial extension would be a significant headache. I put that in red because, yeah, the headache is quite significant if there is intracranial extension. And then we've all heard of these scary things like septic cavernous sinus thrombosis, meningitis, a Pott's puffy tumor. We do see these, and they're not as rare as we think that they are. And then an epidural abscess, subdural abscess, and brain abscess. I mean, this would all be picked up on imaging if you have an indication to think that there could be a complication of the sinusitis. It's also important to understand that we are born with some sinuses, and other sinuses become aerated as we get a little bit older. So it would be quite unlikely to have a 1-year-old, for example, with a sinusitis. It would generally be in your slightly older children, just by nature of the anatomy of the sinus. I know this is a very busy slide, but this is basically the medical management of acute bacterial rhinosinusitis. It is really important that when you prescribe an antibiotic, you are giving the correct dose for the correct duration. And it is a high dose antibiotic for this acute bacterial rhinosinusitis. We go with 90 milligrams per kg per day, divided in 2 divided doses. And if you have a look here, the duration is quite interesting. I know that the pharmacy doesn't always necessarily give as per our prescription, but they really should. Obviously, we do have some kids that are allergic to penicillin, so important to look at the alternative. And then they do mention our augmentin, so amoxicillin with clovanic acid. And this is important to see that this is if there is treatment failure. So generally, an antibiotic should show some kind of improvement at 48 to 72 hours. This is assuming you've made the diagnosis correctly and it is a bacterial infection. But if you don't feel like they would tolerate the augmentin and they may possibly need IV antibiotics, that's also something to consider. And then there are some other options here. But it's a very busy slide. Basically, your take-home message from here is if you are prescribing an antibiotic, do the correct dose for the correct duration, and obviously make sure that the child is not allergic to penicillin when prescribing. I know this is a gross picture, but acute pharyngotonsillitis essentially is your pharyngitis and tonsillitis. The importance here is to understand that it is often an acute onset of a sore throat with an associated fever, headache, and reactive lymphadenopathy with the absence of coryza. So when I teach the students and I try and teach this to the interns, I try and tell them that if there's a runny nose, a runny tummy, runny eyes, or a rash, it's most likely viral and therefore no antibiotics are indicated. Again, this does speak to the above where I mentioned that diagnosing viral from bacterial clinically is very difficult. I think if you have a patient who has a red throat with these symptoms, it most likely is viral. Your aim in the management of, your aim in pharyngotonsillitis is to identify those who are at the highest chance of having group A strep pyogenes. And the identification is that if they're in the high risk age, so your age between 3 to 21, they're therefore at risk of rheumatic fever. Under the age of 3 and older the age of 21, there is no true benefit for that individual, but what you could be doing there is breaking the chain. So your children under the age of 3 could be carriers of your group A strep pyogenes, and they could then go visit a grandparent. So you may end up treating them to try and break this chain. It's uncommon in children who are under 3 to 5, but they are often frequent carriers. So this is generally a case where you could prescribe based on, you're not going to prescribe based on severity, sorry. So here you're generally using the age, so age between 3 to 21. They used to say the cutoff was 5 to 15 for rheumatic fever. They've extended that somewhat. And because of the good use of antibiotics, we've seen a significant reduction of rheumatic heart disease. So the course of illness actually with pharyngotonsillitis is that most will fight the infection on their own. It would be slightly faster with an antibiotic. So the thinking is that if you give an antibiotic to an adult who's 25, they would get better 1 to 2 days faster, but they would fight it on their own anyway. That being said, if someone offered you an antibiotic and said, you'll get better 2 days faster if you take this, I think most of us probably would take that antibiotic. But it's just important to understand the importance of a microbiome. That is a whole nother talk for a whole nother day. But the importance of the microbiome is really rearing its head. It's been linked to a lot of autoimmune conditions, a lot of allergies, and even being linked to a lot of mental conditions. And so we need to protect the microbiome. And if it means that you're sick for 1 to 2 days longer, maybe it's worth it. But again, here, our main thing besides preventing your rheumatic fever is also to prevent complications. So this again is quite a helpful flow diagram. The only problem here is that we don't routinely swab the throat, but if you follow the diagram, you'll see viral symptoms, most likely that it is a viral infection, and it's unlikely that you need to worry about your group A and your beta hemolytic streptococcus. Symptomatic treatment only and no antibiotic is necessary. So yeah, I mean, that's a bit of a tough one because, they have the sore throat, they have the initial symptoms, but the viral features here are what is so important to take note of. Your bacterial features is a little bit, you'll have a look there, tender anterior cervical lymphadenopathy. It's generally quite an acute onset. And then if you did have the luxury of a swab, that could confirm it. But in our setting, we generally don't, and therefore that's where you would prescribe an antibiotic script. And this speaks basically only to ages 3 to 21. So with this, we could also go on to looking at your fever pain criteria. So if you do have an adult who really doesn't look well, who's got a very sore throat, You can use your fever pain or your Centaur criteria, and this could guide whether or not to prescribe an antibiotic. The fever pain score generally talks of if they have a score of more than 4, they could warrant an antibiotic. And if they have a score between 2 to 3, you could do like a delayed prescription. So you could give them a prescription and tell them only to fill it if they don't settle or don't get better. We don't generally have the luxury of this kind of medical management, but something to keep in the back of your minds. So again, complications. We want to prevent acute rheumatic fever. Your Ducker-Jones criteria, obviously, is that if you have rheumatic fever, we don't see this very often. I remember I had a patient who I thought I had very proudly diagnosed as a rheumatic fever and sent to the ward, and I was very quickly told, oh, we haven't seen one of these in years. So, I mean, whether it was or wasn't, I was never actually certain, but we do still need to keep it, in our minds. It's not eradicated. There's still a lot of strep, and there's ever-growing antibiotic resistance. So not to forget about rheumatic fever. A peritonsillar abscess, essentially your quinsy, very important to look in the throat. Cervical lymphadenitis, sometimes that presents at the initial diagnosis of a bacterial throat infection. So that's often par for the course. Mastoiditis, I'll touch on that now, and then post-strep glomerulonephritis. So these are just some of the complications that we can help prevent if we prescribe antibiotics appropriately. So your treatment, again, touching on the analgesia, if any of you have ever had a severe tonsillitis, it's one of the most painful things. So a good, correct dose of paracetamol together with ibuprofen would be very, very helpful. Antibiotics, again, mentioning here your fever pain score and then your age, as well as hydration, really important. You should always document whether the child or the adult has trismus, whether they are drooling, and whether or not they can swallow. If a child has a severe tonsillitis, they cannot swallow, they're drooling, they're not opening the mouth properly, that is definitely grounds for admission. And sometimes they do just need IV fluids or even IV antibiotics. You'll take note here of the different prescription of amoxicillin here for pharyngotonsillitis. And here they speak to being on an antibiotic for 10 days for full eradication. We do have PEN-VK, it does still work, and we should be prescribing it. Okay, acute otitis media is a very common childhood illness. More than 75% will have one episode under the age of 3, and they say 90% of children will have one episode under the age of 5. I think it's really, really important, and we try and drum this home with interns. You need to get used to looking at ears. Looking at ears in children is not easy, but with practice it becomes easier. And familiarize yourself with what you should be looking at. Is the tympanic membrane, does it have a nice light reflex? Can you see? It should normally be like a grayish, reddish color, like pinkish color. It shouldn't be bulging. It shouldn't be hyperemic. And it certainly shouldn't look retracted. That being said, a simple red tympanic membrane could simply be from the child crying. So you need to just keep that in the back of your mind. And that will also help you with regards to your diagnosis as to whether you're thinking it's bacterial or whether you think that they need an antibiotic. The other thing is also if the otoscope is dull, the tympanic membrane could look red when in actual fact it isn't. So yeah, just practicing looking in ears is really, really helpful clinical skill and something that we battle with a bit in POPD. And sometimes we have interns saying, oh, there's a child who's got a pyrexia of unknown origin. And you ask, did you look in the ear? And they haven't. It's really important. And especially in a child who has a fever and you can't find a source, make sure you can document the TMs as well as a child who's vomiting. So here's some of your diagnostic criteria for an acute otitis media. Quite difficult in younger children. They can't always localize pain, but they do tug on the ear. They may rub the ear. That being said, tugging on an ear, rubbing on an ear is also very behavioral. It's soothing for children. So if the mom says, oh no, she always does that, you need to take that history. But if it's a new thing, the child's pulling the ear, they have a fever, they may be vomiting, or they may just be irritable, you need to consider that it is an otitis media. We have a really wonderful speech department. And on occasion, if you're just simply unsure, you can send the child across for TIMPs, and they can tell you whether it's a type A, a type B, or a type C. And this helps you to decide whether there is actually fluid behind the ear, whether the ear is actually completely normal, or whether there's an infection. So that together with your history and your clinical management is very helpful. So very similar flow diagram, helpful to make the diagnosis. I'll go through this a bit more in the next slide. Not this one, the next one. I'll just touch on complications here because, again, this is, I think, where us in the ED need to be so, we play such an important role, is that you need to pick up complications. If you don't necessarily need to manage, a viral upper respiratory in the ED, like that's an outpatient thing. I completely understand that, but you need to be able to pick up a complication. We often get referrals from clinics saying that the child has mastocytitis and they actually have a cervical lymph node. Mastocytitis is often a clinical diagnosis, obviously with the assistance of CT and with your specialists like your ENT. But it's really important to get used to looking in that ear. When you're looking in the ear, tap that mastoid. A true mastocytitis, the child will jump. The adult will jump. It is very, very painful. So get used to looking behind the ears. If there's redness, if there's swelling, if there's a suspicion of mastocytitis, then take it further. It may warrant a CT scan to make a formal diagnosis. Your complications, again, include your meningitis, your intracranial extension, labyrinthitis, and hearing loss. So just to keep that in your mind, what you're looking for. I thought this was really important, the mastocytitis, and it's actually, so in your under fours, only 1.33 in 10,000 will go on to get mastocytitis, and so your number needed to treat is more than 4,000. So it's not that common, but obviously it's devastating if you miss it. Okay, so I learned a lot during this presentation. I don't know if I learned the wrong stuff before, but this was really helpful for me. In a child who presents with an acute otitis media, if they are less than 6 months, they need to be treated with an antibiotic. And this is because it's a very unusual age group. If they are a neonate, they need to be worked up for neonatal sepsis. I don't think anyone, including like a super specialist pediatrician, would confidently say that a neonate has an acute otitis media. They need to have a septic workup before you can just say it's an otitis media. Between the ages of 6 and 2 years, 2 years months, that's not right, 2 years, you treat if it's bilateral or if it's unilateral with severe impact on function. And then if they're more than 2 years, you treat if it's perforated or if they're systemically unwell. So I found this very interesting because most of our patients actually do attend daycare or do have siblings that attend daycare and often present with fevers more than 38. So this is basically saying these are essentially make your patient at risk, is that they have had a recurrent otitis media. In light of the recurrent otitis media, if they've recently had an amoxicillin course, you would then step them up to Augmentin. So that's just an important thing to consider. Obviously, if they're immunocompromised, neonates we touched on. If they have a structural ENT abnormality, so often children with trisomy 21, they have a much flatter eustachian tube. They tend to be at risk of acute otitis medias. And then attending daycare or unvaccinated, you would obviously place a bit more importance on these individuals with regards to antibiotics. Antibiotics, you have 3 different categories. So if you're unclear of the diagnosis and they live across the road or mom's really on the ball and they have access to transport and you think, oh, those ears do look a little bit red, but the nose is a bit runny, the child's not that unwell, it's most likely all part of an upper respiratory tract infection and not something that you're worried is an acute otitis media, you could always tell them to come back if they didn't get better. So that's one option. We don't always have the luxury of that by nature of the fact that we service a really big area in Gauteng. If you think our catchment area is as big as Zandspruit, Cosmos City, even Mildersdrift sometimes, those patients can't easily come back. And sometimes we end up prescribing antibiotics just by nature of social circumstances, which is probably not necessarily right, but it may be a good reason. Delayed antibiotics, so again, if it's easy for them to come back, and watchful waiting with a script. So this is often, like I would imagine, more in a private setting, is you give the script and you say to the mum, okay, if the child is still spiking in 48 hours, go fulfill your script. And that can be quite helpful because often the symptoms settle and they actually didn't need the antibiotic in the first place. And then your immediate treatment would be your category, so above very young, severe, or bilateral, and that would be an indication to give antibiotics. I've just slid this in that it's the exact same management as with your acute bacterial rhinosinusitis, and it's again a high dose of amoxicillin or possibly your Augmentin if they've had a recent treatment. I've really just touched on this. Epiglottitis is rare, and thankfully it's rare. I know we did have one in the ED not so long ago. The important picture here is the child is toxic looking. I remember reading toxic looking in the Cuvadio when I was a med student, and I didn't quite understand what it meant. But once you've seen a toxic looking child, you know exactly what they're talking about. They have this tripod position, they're leaning forward, they're drooling, and they have stridor. Do not examine this child. Do not try and visualize the throat. Call specialists, call ENTs, call your anaesthetist, and prepare for an advanced airway. This is a really, really catastrophic illness if not managed appropriately. As you can see, the X-ray there has the thumb sign. But if you are suspecting epiglottitis, rather just call the specialists out and be prepared for an advanced airway. And then your quinsy, again, I mean, your number needed to treat is so many. It's quite a rare thing. I mean, to be honest, I can't say I've seen it in the pediatric outpatient setting. I mean, I've seen it before, but we don't see it often. And again, this child is generally quite unwell and does need an ENT consult. We do often get referrals from the clinic to say that it's a quinsy, but in actual fact, it's just really large tonsillar hypertrophy, generally your grade 3s or 4s. So it's important to differentiate between the two. So antibiotic stewardship, I think I have mentioned it before. We've seen a worldwide increase in antibiotic resistance, and studies suggest that this has contributed to inappropriate use of antibiotics, particularly for upper respiratory tract infections. We feel like we're not doing a good job, or we feel like we haven't done what the patient wants us to do if we don't give an antibiotic. And many of the patients will actually say, and what about an antibiotic, doctor? And we often feel like we need to explain, or over-explain rather, why we're not giving it. But if we think of the long term, it's really important to follow the guidelines when prescribing. Antibiotics prescribing should be vigorously discouraged in an era of growing antibiotic resistance, and our increasing knowledge of the vulnerability and the importance of the human microbiome. I mean, you just have to do a little search on microbiomes, and I think it will change so much of our thinking. It's been linked to ADHD. It's been linked to so many things, to depression. I mean, here we think that we're just helping the mum by prescribing a penicillin, but in actual fact, we may be creating many, many, many more problems going forward. It's very important contradiction in treatment of respiratory tract infection is that the cohort most likely to receive antibiotics, which is your under 5s and under 3s, are actually least likely to have a bacterial etiology and the least likely to develop complications. So this comes with your watchful waiting. If you have a parent that is really on the ball, or you have a patient who can come back easily, there's nothing wrong with watchful waiting. In actual fact, you may be saving their microbiome. And again, I've mentioned this before, it's clinically almost totally impossible to distinguish between viral and bacterial. So rather err on the side of caution, but you'll follow your severity approach, and you'll follow your guidelines with regards to your pharyngotonsillitis, with your ages. And if you follow the guidelines and the suggestions, then we're unlikely to miss those who are at risk, and we're unlikely to overtreat with antibiotics.